Hello, 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 my friends. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is time for our National IC Support Group meeting. It is Sunday, April 18th. I hope that you're having a great day today. So far, we're having a pretty great day here. We're simulcasting live on YouTube and Facebook, and we're just getting things all amped up right now. And let me just fix this over here. All right, Facebook. So I have two different cameras. I got a camera here and I got a camera there. So if I'm looking around, I'm trying to fix this. This is hard. Let's see if I can fix this just a little tiny bit. Sorry, Facebook. I know you're all, there you go. Hey, that might be a little bit better. All righty. Let's do this. Let's do this. Well, how has your week been? I don't know about you, but man, I have had a rough week this week. Found out I have got to have an epidural on my back. I'm not happy about that. All righty, here we go. Hold on a sec. All right, so Facebook. You guys just give me 1 second, okay? Facebook, you're being weird. Facebook. I cannot see what you're writing. No. It won't show me anything. Hello, Facebook. Hi, you guys. So, hey, would you write something in chat with Facebook, please, so I can see you? And same thing, you guys on YouTube, same thing. Can you go, please write something in chat so I can make sure I'm seeing everything? Because we're broadcasting on two different internet services right now. So, Facebook, why can't I see what you're writing? Is that it right there? Okay, well, there's something. Okay, I can, now I can see a few comments there. Oh, there we go. Hi, Carla. Hi, Debbie. Hi, Teresa. Hello, Sherry. Megan says she's had a crazy week. All right, now you guys on YouTube, why can't I see what you're doing? Debbie says, what type are you getting on your back? I'm not sure yet. I got to meet with I had an EMG on Monday, and an EMG is where they stick needles in various parts of your body and run current through it to see how you're looking there. Anne says, cannot properly get diagnosed. One doctor says IC, another doctor says overactive bladder. So what can it be? So Anne, what we need to do is subtype you, because both of those names are not specific enough. There are lots of different conditions that can cause bladder symptoms. Lots. And so interstitial cystitis and overactive bladder are a bit of a grab bag diagnoses. They don't necessarily give you what we call an intuitive treatment pathway. And so what we have to do is try to get a more narrow, specific diagnosis so that you know what to do next, right? Hello, Kelly. Hello, Sherry. Nice to see you. Hi, Lauren. Hi, Sherry. Who's new? Welcome. Welcome, my friend. Everybody is welcome here. And you know what the best part about doing an online support group meeting is? You can get up and go to the bathroom whenever you need to. Isn't that great? Hello, Matthew. Nice to see you. Hello, Sherry. Thank you for the 150 stars. Carla says, I've had some complications from my hysterectomy. Rectocele is an issue, so I have to see the surgeon this week and likely surgery. Yeah, sometimes that can happen. Sometimes you can get little mini prolapses and things like that after hysterectomy. Hello, Mary. Hi, Lisa. Hi, Sherry. Hi, Ingrid. Hello, Elizabeth. Thank you for the stars. Teresa says, I miss my Cysto Protect. Something in Miss Cysto Man irritates my bladder. So you guys, Cysto Protect was for many, many years our top IC supplement. Unfortunately, it has had a checkered couple of years. We couldn't get it for 10 months a couple of years ago. And now we have been in an extended manufacturer's delay. And the challenge with that is that they keep pushing it back. All the production facilities that are making anything are way back because they're having trouble getting their raw ingredients. And that's been particularly true with Cysto Protect. I did get an update. The latest update is that they thought they would have it sometime in May. In the meantime, there are lots of other supplements you can do besides Cysto Protect. Cysto Mend is one. And it's interesting. So Teresa says something in the system is irritating your bladder. Baffling because it's pretty much identical. I'm not sure why that would be. Lisa says, does Elmeron cause glaucoma? Uh, Not that we know of. Elmeron causes changes in the retina, pigmentary maculopathy. Elizabeth says, can you tell us what the reaction to the flu vaccine that had you in the hospital? Okay, so I'm not talking about COVID. I had my COVID shot. It was fine. I've always gotten flu shots and I've never had a problem with it until last September or October, I had a flu shot. Now, I got to understand my stress level was massive. We were in the middle of fires and evacuations and COVID and all sorts of stuff like that. And I was at the time drinking every day a lot of decaf coffee because I'm IC subtype 3, pelvic floor driven, IC subtype 5. I'm not IC subtype 2, bladder wall driven. So I could get away with doing coffee and things like that. Unfortunately, I just got to the point where I'd had it every day for about 7 months. And after I had my flu shot last year, I went to Starbucks as a reward, got myself a venti decaf frappuccino, only it wasn't decaf, it was caffeinated. And when I am given caffeine, I shake like a leaf and my heart races. And that's exactly what happened. My heart started racing that night, but I started throwing PVCs, which are very strong contractions. And it started around midnight. And I ended up, it was very scary because I was throwing PVCs like literally every 2 or 3 seconds. And I drove myself to the emergency room and got in, and they did the heart monitor. They saw them. They said, yes, you're absolutely having PVCs. And what they found two things. I was low in potassium, which makes sense because I wasn't eating because of the fires. And also, um, he felt that the caffeine was just way too much for me. And ironically, I've had several periods in my life where I can do coffee for about 6 months, and then it's just like it upregulates my entire central nervous system and my heart, and then I end up throwing PVCs, and I've got to stop for 5 years. So he sat me down. He goes, Jill. I'm like, what? He goes, you may never drink coffee again, even decaf. You're too sensitive. And that's what we expect with people with IC subtype 5 central sensitization. So my reaction to that flu shot has nothing to do with my reaction to COVID. Carrie says, can you touch on supplements? My hair is thinning and I want to take collagen. You shouldn't have any problems with collagen. You shouldn't have any problems with biotin. You got to be careful with vitamin C in the form of ascorbic acid. Calcium ascorbate's fine, but ascorbic acid can be irritating, and B6. Anne Rush says 2 differential diagnoses. One doctor says overactive bladder. The other says IC. Which is it? All right. So, and we're going to come back to that, and we're going to do some subtyping. So, guys, let me just introduce myself for a moment. And again, we're simulcasting live on YouTube and on Facebook. So if I'm looking here, I'm looking at YouTube. If I'm looking here, I'm looking at Facebook. My name is Jill Osborne. I'm the longest serving IC support group leader in the United States. And at this point in time, pretty much the world, I think, although I don't know if Germany's still meeting. I've said that before. I bring to you 3 college degrees, an award from, I was a presidential fellow. I have a degree in chemistry. I have a degree in drug development pharmacology with a rare surgical internship. So yes, I did surgery for a year. And then I have a master's degree in psychology. And the IC network was my doctoral dissertation proposal on how to bring support to somebody who was homebound. And because my IC hit, or my bladder pain hit when I was 32. And it just changed everything. I mean, one night you're functional, one day you're completely functional, life is good. And the next day, bam, you have what feels like the world's worst bladder infection. And it doesn't go away at first. Now, I don't have those symptoms anymore. But early on, it was such a traumatic injury that the pain was insane. And I am living proof that you can get better. But one of the things we really clearly understand now is that there's tremendous diversity in this patient population. We're not the same. And that was the gift that starting a support group gave me, because it helped me see, number one, I wasn't the worst patient in the world. I thought I was. Number two, that your presentation and my presentation might be a very, very different. For some of you, IC begins in childhood. For others, after menopause. For some of you, IC begins after having a baby, while for others, IC begins after falling on your tailbone. And so, here, hold on a sec. Let me do this. There we go. Now I can see YouTube more effectively. There you go. So, today we make a more specific diagnosis. And it's interesting when somebody calls me and they say, well, I was diagnosed with IC, yada, 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 20 years ago. It's like, okay, well, we've learned a lot in 20 years. So what I really want to know is what is your unique presentation of IC? So let's go over those variants. And I do that with patients on the phone. So we have 5 fundamental variants. I use a system that was created by Dr. Christopher Payne at Stanford University. IC subtype 1 is Hunner's lesions. Those are big, bloody, bleeding wounds in your bladder that have now been connected to viral infections. IC subtype 2, bladder wall driven. That means you have a legitimate bladder wall injury or problem. So in this variant, we're going to look for chemotherapy. Do you have some sort of medicine-induced or chemotherapy-induced bladder wall irritation? Or ketamine, were you exposed to ketamine? Could that be part of the problem? We're going to look at estrogen atrophy because aging matters. If your symptoms started after the age of 50 or after having a hysterectomy or after going on Lupron, that's not a disease. That is what happens to every woman's body when you lose estrogen. It's called the genitourinary syndrome of menopause, and things just get dry. Your bladder wall gets dry. We're also going to look for chronic infections. We're going to look for chronic fungal infections and chronic bacterial infections, usually doing next generation DNA testing, and I can go into that a little bit later. IC subtype 3 is pelvic floor driven. These are the patients whose symptoms began after having a baby or falling on their tailbone. That muscles, if your muscles are messed up down there, that's going to mess up your bladder. I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? For some of you, you legitimately sustained a bladder wall injury. Let's say you went through chemotherapy, or let's say you were drinking way too much diet soda or soda. You weren't drinking water, you're just drinking soda. Your bladder is not designed to support high levels of soda or acid over time. It will eventually start damaging your bladder wall. And because your bladder is screaming in pain, your muscles are going to get tight to protect you. And so our therapeutic priority for you as a chemical injury patient is to calm and soothe your bladder. We know if we calm and soothe your bladder, your muscles will release and things will be back to normal. You know what? I've hardly drunk anything today. Hold on a sec. I am drinking right now Dandy Blend herbal coffee. Completely acid free. Tastes really, really good. You can make a latte with it. You make an iced coffee with it. And let me just show this to you real quick. So Dandy Blend comes in a little, just a little container, and you just open it up, pour it in hot water, put sugar in it, coffee or cream in it if you want. Bam, you're ready to go. This is available on our website too, by the way. I love this because I miss my coffee, but my heart says no more, no more. All right, let's get back to our chicken versus the egg dilemma. So for some of you, this begins after a bladder wall injury. Your pelvic floor muscles get tight, but because we know your symptoms began after a bladder wall injury, we know we have to focus on the bladder. But guess what? This is one of our smallest subtypes. The bigger subtype are the patients whose symptoms began after a muscle injury, after a muscle trauma. Now, you have no clue you have a muscle injury. Your first symptom is frequency urgency. Your symptom is infection. You are 100% convinced that you have a bladder infection. You call your doctor, hey man, I'm peeing all the time. It hurts. My urethra hurts. Can you please give me some antibiotics? And many doctors will say, sure, they'll just throw them out at you. They won't even culture. But guess what? Sometimes they don't work. And if they don't work, what are you going to do next? What are you going to do next? You're going to call your doctor back. Hey, doc, it must be a drug-resistant infection. Can you give me a different antibiotic? It doesn't work. The doctor cultures your urine. There's nothing in your urine. They do a next generation test. Your urine's fine. And you go, oh crap. The doctor goes, all right, we got to rule out some other stuff. And eventually they might diagnose you with overactive bladder. Now, overactive bladder means you got frequency urgency, but without pain, just frequency urgency. They give you overactive bladder meds, antispasmodics, Detrol, diturpan. They don't work. And you're like going, what the hell? You want your life back. You can't go anywhere. You're stopping at every freaking bathroom that you know in town. You could write a book on bathroom access for your neighborhood. You know where every single one of them is. And it's very frustrating. You want to go to a movie, but you don't, you say no. Well, of course we can't with COVID right now, but before COVID, you know, I stopped going to movies because, in fact, that was my first goal after things started getting better was could I go to a movie and not upset people? Because in the old days before I see, you'd hang out with your girlfriends or your friends and you all get in the car together and go to the movie, bam. And you watch the movie, go home and have fun, right? But when you have IC and you got to leave in the middle of the movie with a flare, everybody else has to leave with you because they're the ones who drove. So, we compensate. We start driving ourselves so that we can leave early, right? All right. So, overactive bladder, Detrol and diturpan don't work. And you're just going, oh my God. You go back to the doctor and you're begging, doctor, please, please help me. What the hell is wrong? And the doctor goes, God, I hate to break it to you, but I think you've got this incurable bladder disease called interstitial cystitis. I'm so, so sorry. They throw the diet at you. They throw Elmeron at you. And they say, go read about it on the internet or go over and look at the IC network. And you're hearing, what do you hear? Incurable bladder disease. And you just freak out. Who wouldn't? So you do what the doctor says. You do the Elmeron. You follow the diet. And you do this for years. And you know what? You're really not that better. You still flare. You might still be having symptoms every day. And the question is why? Why are you still having symptoms every day, even though you're doing bladder therapies? Because maybe it's not your bladder. And when these patients call me, we spend a lot of time going back in history. Tell me what happened when your symptoms began. What was going on? Were you in an accident? Did you fall? Had you taken a car ride? Are you newly married? Whatever. Did you fall off a ski lift? Were you an athlete? Anything at all like that. And you know what we find in the great majority of patients? Tailbone injuries. So when my symptoms began in 7th grade and I had frequency urgency, I had just broken my tailbone. I was diagnosed with a urethral stricture. I went through about 100 urethral dilations, which is because they say your urethra's narrow. But nobody went, well, why the hell is her urethra narrow? Muscles, tight muscles. It's because your urethra goes through your levator ani muscles. And if your levator ani muscles are tight, bam, you're going to have problems. And so we knew in 2008, when the National Institutes of Health released their first clinical trial on pelvic floor physical therapy, it outperformed bladder therapies substantially. And when that study came out proving that pelvic floor physical therapy was more successful than bladder therapies in the great majority of patients who tried it, that was when the IC movement was put on its head, because up to that point, everybody's going bladder disease. But if it's a bladder disease, why would physical therapy help? And that was when we all went, uh-oh, guess what? Maybe it's not a bladder disease for some of you. Maybe it's a pelvic pain syndrome. Maybe it's because your muscles are screwed up. And the irony is, if you go back in the literature 50, 100 years, and you look at those early papers, urologists were describing muscles so tight they resembled tight piano strings. And yet urologists play in the urinary tract. They were like, all right, tight muscles. They didn't do anything about it. Medical schools and Western medicine fails the typical IC and pelvic pain patient because doctors play in their sandbox. Urologists like to stay in the urinary tract. Gynecologists like to stay in the reproductive tract. Gastroenterologists stay in the bowel, et cetera, et cetera, et cetera. They don't look at relationships. And it's relationships that matter. Muscles can change the behavior of the bladder and the bowel and the reproductive tract. If you have tight muscles, guess what? It's hard to pee. When you go sit on the toilet or stand in front of the toilet, can you release your urine right away? You have to wait 5, 10, 15, 20, 30 seconds before you can release urine. That's because you have tight muscles, potentially. Um, let's see, what else was I gonna look at? Okay, do you struggle with constipation? Constipation often happens because of tight muscles. Do you have pain with intimacy? Either for a woman, pain with intercourse or pain at orgasm. And for a man, pain at orgasm. For a man, it can feel like somebody's shoving a razor blade up the tip of your urethra. That's actually referred pain from your pelvic floor, right? And so imagine this patient. You are completely invested in bladder therapy. You have spent 20 freaking years doing bladder therapies and you're not better. So the American Urology Association says, if you're not responding to therapy, if you're getting worse rather than better, take a moment, take a step back, and let's revisit the diagnosis. Did we miss something? Did you fall? Were you hit by a car? Did you have a lot of babies? Were you an athlete? Were you a warrior? Were you a paratrooper? Were you a football player? Were you an ice skater? Were you a gynecologist? A ballerina? Where you sustained multiple pelvic traumas? Were you a bike rider? I was working with a bike rider on Friday, and she'd been riding bikes she was in her 60s. She'd been riding her bike since her 20s, and her symptoms began in her 20s. And when we started looking at her symptoms, it's like it's starting to check all the pelvic floor. And then she said, I've had sciatica for years. Sciatica is a pelvic floor muscle so tight, it's squeezing the sciatic nerve. And it's like, hon, guess what? You need to go have a pelvic floor assessment. You're a bike rider, and you need to tell them that you're a bike rider because there's something called bike rider syndrome that happens. And it happens at a young age, it can happen at a young age. Here, hold on. So IC subtype 3, pelvic floor. IC subtype 4, pudendal neuralgia. So these are the patients whose symptoms are not being driven by the bladder wall or the pelvic floor. They're driven by dysfunctional nerves. So if you do have sciatica, if you have pins and needles, if you have persistent genital arousal disorder, that's a sign that you've got a nerve issue going on. And usually it's that nerve has been injured because of tight muscles or perhaps a trauma like that. So if you have pain when you sit down that is relieved by standing up, you have pudendal neuralgia. And we got to focus on that. No bladder therapy is going to fix that. I see the last subtype in the pain system is called central sensitization, chronic overlapping pain conditions. And these are the patients, this is also one of my subtypes, who have IC, IBS, vulvodynia, characterized or migraines, fibromyalgia, characterized by super sensitive skin, wicked sense of smell. You can, like, we just got a new toaster and I fired it up outside, and oh my God. Oh, I just do not do well with smells at all. And so for people who have chronic overlapping pain conditions like this, we again look at nerves. And usually there is either some genetics involved, hello, redhead, or there was some sort of trauma, often in childhood, which basically amped up the nervous system and has made the nervous system more sensitive. And so for this group of patients, again, bladder therapy is fairly useless. We need to be doing things that will calm the entire nervous system down, like palmitoethanolamide and good anxiety management. Anything that will amp up nerves, we got to calm them down. Got to get control of that anxiety, get control of that stress, and maybe try some therapies that will calm nerves down. So we got 5 fundamental variants here. Hold on. And you guys, just so you know, I slept in my recliner last night. I totally tweaked my TMJ 2 nights ago and almost dislocated my jaw. So I didn't talk much yesterday. We'll see how long I can last today. And I also had to take muscle relaxants. So if I'm a little foggy, that's why. Catherine says, I'm finding red meat triggering. Is that common? It's more common depending upon sauces you're putting on it. But I will tell you as an IBS patient that I do much better with very, very small amounts of red meat. But we need our protein. And for those of us who are anemic, we definitely need red meat. So just be careful of the sauces you're doing. Like I made beef stroganoff with Worcestershire sauce. And I'm always a little bit worried about Worcestershire sauce a little bit, but it was fine. Catherine says, are low oxalate diets recommended? You just have to experiment and try them. Oxalates are chemicals found in food like chocolate and berries and spinach that create strong crystals in your urine. And those crystals can be quite irritating to the urethra, to the bladder wall, and to the vulva. All right, hold on a second. Y'all talking a lot here. Arlene says she's off coffee. Excellent. Hello, Donna, my friend, my sister. How are you, Donna? Carol says I use Intra-Orosa. Ronin says, can estrogen placed vaginally be irritating? I wonder if I need to avoid using it vaginally. You know, hun, the reason why estrogen can be burning, it can cause a burning sensation is because your skin is freaking dry. That burning is a direct reflection of the quality of health of your skin. And so usually after about 2 weeks, that burning goes away because your skin immediately starts using that estrogen to produce mucus. But you have to kind of ride through that burning sensation. The only qualifier to that is Premarin, which is from pregnant mare urine that tends to cause more chemical irritation. We do better with a compounded estrogen cream. Ronine says, let's see, hold on. Okay, so I hope that helps. When you place estrogen in your vagina, you've got a much better chance of it getting through to your bladder. Carol says, will getting a hysterectomy make a cystocele better? It's a really good question for your doctor. I don't know how to answer that question. I don't. Remember, guys, I can't give you medical advice. My job is to educate you, empower you, and kick you in the butt and get you back to the doctor, right? All right, let me come back to Facebook here. Margie says, I got told my large intestine was severely constipated, but the doctor never told me what to do. And does that mean I can't have gluten? Constipation doesn't have anything to do with gluten. Gluten can be more irritated. What that means, hon, is that you're probably quite dehydrated, not eating enough fiber, and or maybe taking a medication which causes constipation, like perhaps an antidepressant or pain medicine. You got to get your fiber uptake and your water uptake up there, and you might even need to do something like Miralax to try to get things moving along, or an enema, a fleet enema, just to get things moving along. Hey, man, we've all been there. You guys, those of you watching, just understand I have no shame. I will talk about anything, including using enemas. My doctor said IC, but also vaginal atrophy. Can't imagine both. Honey, they're the same thing. What you're missing, now listen, your bladder needs estrogen to produce that nice thick coating of mucus. Your bladder is like your mouth. It's a hollow organ covered with a thick coating of mucus. We call it the mighty mucus. And the purpose of that mucus is to be a barrier. It protects your bladder wall from irritants in your urine and bacteria in your urine. But it is estrogen dependent. So when you're young and you have lots of estrogen, you have lots of mucus and you can get away with crap. When you're older, you have much less estrogen, you have much less mucus on your vulva, in your vagina, in your urethra, and in your bladder. And that's going to affect everything. They're exactly the same thing, hon. Mary, it's called the genitourinary syndrome of menopause. You need to Google it. So if your IC symptoms began as you got older or after surgical menopause or chemical menopause, then you probably don't have IC. What you have is estrogen atrophy, genitourinary syndrome of menopause. Hi, Vicki. Hi, Deborah. Hi, Carrie. Hi, Megan. Anne asked what multivitamin does not have vitamin B's in it. Hun, most vitamin B's are fine, and you need B12. It's B6 that can be a bit irritating, but the vitamin that I take is, where is it? Here, let me go get it. Hold on, I'll be right back. Here it is. It is called Bladder Smart. It is a low acid formula, right? So, the great majority of IC patients do not tolerate regular commercial multivitamins well because they have high levels of vitamin C and high levels of B6. What this does is instead of using ascorbic acid, it uses calcium ascorbate, but the source of calcium in it is calcium glycerophosphate, also the active ingredient in pre-leaf, which is an acid reducer. So this is a very, very low acid formula, right? And this was my idea years ago. I brought it. I've told that story before about Far Laboratories. The CEO of Far Laboratories asked me if you could make anything for an IC patient, what would you make? And I went, I know exactly what I'd make. It'd make a low acid vitamin. And they did it. It was called Multi-Right. Unfortunately, the Multi-Right pill is just too big. And so I asked Natural Approach Nutrition a couple years ago if they would take a stab at it. And that's what this is. And you can see how small the capsule is, right? Because I have trouble swallowing big pills. I need smaller capsules now because I am a wee bit older. Lauren says, you know what happened to the Equinox ship 4 study a few years back? I was in this study till phase 3 and they stopped. Yeah, they didn't meet their phase 3 benchmarks, and that's why they stopped following that therapy. And we really, really, really tried to get them to continue, but it just wasn't a moneymaker for them. Tina says, Jill, you and I used to talk a lot when I first got it, and you helped me a lot. Thank you. Matthew says, I got my first symptoms at 25 while in the military. I feel like I've been living in torture for the past 10 years. Finding a good doctor is hard. My last urologist wanted me to use a Valium suppository. So, Matthew, here's the deal. Dude, here's the deal. I work with a lot of guys. I actually sat on the U.S. Army IC research panel for many years. IC is funded by the Army through the congressionally directed medical research program. And what we did in that is allocated millions of dollars for the study of IC. And then I was also on the drug resistant infection panel too 1 year. And that was so cool. So incredibly cool. I'm going to tell you that in my office here, now I've been working with patients for 28 years. 90% of the men that I work with, I can find a pelvic trauma in their history. So as an example, I was working with a medically discharged paratrooper whose symptoms were just insane. They were so bad. And they'd given him antibiotics and then Flomax and prostate meds. And then they gave him the whole IC lecture, yada, 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 yada. No, so he calls me, this was like 3 or 4 years ago. And we go through his symptoms and it's like, okay, so can you pee right away? He goes, no, it takes a while to get things started. It's like, okay, so that can be a benign prostate hyperplasia, or that could be tight pelvic floor muscle. So tell me, what did you do when you were in the Army? He goes, well, I was a paratrooper. And I went, oh, so do you remember any really particularly bad falls, like right on your tailbone? He goes, oh yeah, all the time. Happened several times. It's like, all right, you need to go have a pelvic floor assessment. His symptoms were driven by muscle injury. And I would bet you bucks, Matthew, that the same thing happened to you. It'd be really interesting to hear what your history was. Were you a football player? Were you a bike rider? And then what were you doing in the military? And do you remember any pelvic traumas? I'm going to tell you the pelvic floor physical therapy is curable. I mean, can cure patients. When Dr. Payne created a subtyping system, he railed on the fact that patients were told that this is incurable. That's wrong. It is curable for many of you, especially if you have a pelvic floor injury. Pelvic floor physical therapy is stunningly successful. And the reason why they wanted you to use the Valium suppository is because it relaxes muscles. What does that mean? It means you have tight muscles. So we got to figure out why your muscles are tight and get them into their proper position. Carry hope, my dude. Carry hope. I'm very surfer today. You guys, come on now. I'm wearing my kind of like my surfer boho outfit. So I'm going to be embodying a surfer girl today. Anne says, are flares different with IC as compared to OAB? They're again, you neither word is really specific enough. I think the question is can you have different types of flares? And the answer is absolutely. You can have different types of flares. You can have a muscle flare, you can have a bladder wall flare, you can have a stress flare, you can have a hormone flare, all sorts of flares. Mary says, why do docs all recommend pelvic floor physical therapy if you have a bladder wall issue? Well, Mary, that's because whenever you're in pain, your muscles get tight to protect you from the pain. You can't, they're not separate and distinct. They come together. They are too functionally allied to not have both involved. Both are involved. You have bladder sensitivity, you got pelvic floor tension or pelvic something going on with your pelvic floor. They go hand in hand. Well, we've got to figure which is primary, which is secondary. Because again, for that patient whose symptoms began with a muscle injury, you could be on bladder therapies for 20 years and never get better. We don't want that to happen to you. So we want to make sure we're working on the right anatomical problem. Okay, so you guys, I need to talk to you about something. So normally when I do these meetings, I usually do like a 30-minute lecture and then I dive into your questions. And somebody's asking about Elmeron, and guys, with the Elmeron, please go to elmeronlawsuits.org. And Lisa says your doctor thinks that glaucoma is related to the Elmeron. Lisa, I'd be happy to talk with you. What you should do is go to elmeronlawsuits.org and call the attorneys and see if they're seeing any of that, because they are deep into the early research with Elmeron. Man, they have found stuff I never found. Okay, so I want to talk to you about something real quick. And there's kind of two facets to it. Facet number one is that after I did my meeting last week, I got a really nasty email from somebody that I've known for years, 20 years, who I hadn't talked to in a decade. And he basically just called me a poser. You know, you're just a poser. And it made me think of, I have a really good thick skin. I mean, it's pretty hard for anybody to upset me. And it didn't really upset me because I don't let a stranger upset me to that point. But I want you to understand that my position could be filled by any one of you. The more, the better. The more, the better. There are millions of patients with IC and pelvic pain and all this sort of stuff. I am everybody is welcome kind of person. And if you want to start a support group, do it, because we need the next generation. Because guess what? I'm not going to be here. I mean, I want to be here for as long as I can, but I'm 60 freaking years old. I've been doing this for almost 30 years. Who's going to come after me? Who's going to take the helm when I can't do this anymore? And the reality is that our top IC doctors also are getting close to retirement. And so this is about cultivating and nurturing the next generation activists because we need more people like me, like you, who are willing to step forward and put the time in to help other patients and kick some butt in Washington, D.C. and among researchers, right? And over the years, I've had a number of patients say, um, gosh, some are very thankful that I answer the phone and we have a team and we have a whole infrastructure that helps patients and we do research. We're doing the only COVID and IC research right now, right? And so we fill a very important and unique niche. But if you're watching, this is what I want to say to you. We got started at the same time. You got started with your group exactly when I got started with my group, because that's when we met years and years ago, 28 years ago. So what's the difference? Why did my group grow and yours not? And it's about time. It's about time in. Every patient has to put the time in to study IC, to present your case, to build skills so that you can work with your doctor. And I was thinking about the difference between the work that you've done and the work that I've done is that I've written a magazine for almost 20 years. I've written 1,000 articles on IC easily. I've worked with every major researcher I can. I have an open door policy. Anybody can call me, but nobody can call you. And nobody's ever been able to call you. And I think that to be successful, you have to be so passionate about the topic that you will put every minute that you can into it. And that's what I've done. And I'm looking for the next passionate person who wants to help people too. And I will help you get started because the more the merrier, the more perspectives, the merrier. And so I just kind of want to encourage anybody out there, if you're thinking about starting a support group, do it. I got a whole section on our website, how to start a support group. Go over there, do it. We need you. There are patients out there you right now can help. You got to be educated. You got to be informed. You can't let your biases hopefully change what you're saying. You got to be fairly neutral. But I will help you be a support group leader if that's what you want to do. And I understand the frustration at seeing the IC network grow and your group not growing. I think the only difference is that I'm here. You can see my face. People talk to me every day. Right? And I love my job and I think it shows. I hope it shows. Okay, so enough on that. Have a thick skin, my friends. You got to have a thick skin. When you're a support group leader, you can, because you're talking with people every day, some of whom are really struggling, it can be really, really depressing. And that is why, if you look at my room here, what do you see? Love. You see all these happy things because I have to have that to get through my day. I've got to have something to balance the stress with the other good part. So I hope did that make sense, guys? You got to put the time in. You got to put the time in. Whether you're an athlete, you know what? Why am I doing this? Oh, you know why? Because I put this on there. All right. Now I'm not going to squirm. I'm a squirmer. All right. Donna says, website acting a little funky and it charged me twice for my membership. Can I get a refund? Of course you can. You guys, if you ever have any issues with our website, you absolutely call me. We'll figure it out. Catherine says, don't listen to that critic. You gave me hope when I was really low. Please know that. Yeah. Thank you. Thank you, Catherine. I mean, that's how I feel. And nobody's perfect, and I'm going to make mistakes just like you're going to make mistakes. But I'm going to do the best that I can to give you good, solid, vetted information. I always wondered why God had me get these weird drug delivery degrees combined with psychology degrees. Now I know, because it's the perfect degree set for doing this work. All right, let's get back to this. Hold on, let me get another drink. Megan, when I'm at work and I get stressed, I feel tightness in my bladder and it's really uncomfortable. So you got to look at how you're sitting. You got to look at the chair that you're sitting on. Are you getting up? Are you moving around? Are you ergonomically correct? Are you crossing your knees? You're never supposed to sit with your knees crossed. That's going to restrict blood flow in one of your legs. So look at ergonomics on where you're working, also making sure you're getting up and moving around. I have a rule in my office that many of you know, and that is if you call and we have a long conversation, I've got my headset on and I'm out walking in the yard. I'm not going to sit and talk on the phone. My pelvis will not allow me to do that. Nancy says, I wish more urology doctors took an interest in it. I've seen through the year, some I've seen through the years will fill my meds, but they're more interested in male prostate. It's true. Female urology and male urology are pretty different, and doctors have their own specialties and their own preferences. Some urologists go into urology because they love doing surgery. They don't want to work with a chronic patient. Daniel says, if my IC pain and frequency is solely based on diet, will it help? Well, okay, but Danielle, that's not specific enough. You have to be more specific than that. So the question is, why are you diet sensitive? Are you diet sensitive because you have estrogen atrophy? Or are you diet sensitive because your muscles are so freaking tight, it's restricting blood flow to your bladder and your bladder wall's not healthy? Chicken or the egg, right? We have to get down to the fundamental anatomy. You are an anatomical mystery to be solved. And if it's estrogen atrophy, we know what to do. All right, hold on a sec. Megan says, she's had no children, never got into an accident. You've had bladder problems since you were born, but no one else in my family has bladder problems. Well, so again, we have to look at your anatomy. Could you perhaps have a birth defect? That's possible. Or could you have, for example, one leg longer than the other? You would have been born with that. If you've got a substantial difference in your leg length, then that is going to put your pelvis at an angle, which is going to put your pelvic floor muscles under greater stress. So, you know, I'm, what I would want to know is sex comfortable? Can you have sex or does it hurt? I think having a pelvic floor assessment is critical in the diagnostic review for every single patient, and every IC specialist in the country does that at the very first appointment. Nancy says, I noticed if I have a really bad flare, Valtrex helped take the pain away. My new doctor I got several years ago stopped prescribing it. Did not believe it. I don't even remember what Valtrex is, to be quite honest. Hold on. I got to look at it. Hold on. Oh, it's the antiviral. Okay, so hold on a sec. Where did it go? There it goes. Okay, so here's the deal. European researchers were the first to reveal that they discovered virus in the urine of some patients. And they found polyoma BK virus, polyoma JC virus, HPV, Epstein-Barr, herpes. And the US government, the National Institutes of Health run IC research team, the MAP Research Network, also last year released their first viral study where they too absolutely found viral infections in a small subset of patients. So if Valtrex worked for you, I would guess that that would probably be why, that you might be in that small group of patients, IC subtype 2, chronic infection, chronic viral infection, and it's a next generation urine test that would help reveal that. Deborah says, who do you see for your pudendal nerve? Um, a physical, usually gynecologist, they might send you to a physical medicine specialist, pelvic floor physical therapist, and or an anesthesiologist to maybe do nerve blocks, or a pain specialist to do nerve blocks. What is going on here? I gotta pop this out. Oh, better. You guys, thank you so much for your kind words. I really appreciate it. Pamela says, had it years, so done with pain, something needs to happen. So again, Pamela, what the AUA says is if you're still in pain, if your pain is getting worse rather than better, girl, it's time to take a step back, revisit the diagnosis, maybe see another doctor, may get a second opinion, have them look at your skin health, at your muscle health, et cetera, et cetera. I would want to know too if you might have any nerve issues going on. Megan says, I stand all day at work because my desk is high and I have to step on a step to get to it. So look at your shoes, Megan. I think the absolute best shoes are Hoka's, Hoka One One shoes. The Bondi 6 the Bondi shoes have massive cushioning, and that might help you tremendously standing. Kathy says, you help me more than my doctors. I feel most of them are just business and I'm a paycheck. Lauren says, you've been such a huge help and advocate for us. Debbie, thank you so much for the stars. Brenda says, will this be available afterwards? Yes, it is. It is recorded on Facebook. Vicky says, I'm still doing estrogen because when I'm worse when I go off. That makes total sense. Mary says, where can I get some pear juice? Can you make it? Just look for organic pear juice. Just go to any grocery store, see what you can do, but just make sure it's organic. It needs to be organic. Quite a few of you are talking about aloe. Okay, Shirley says at 49 it froze. Interesting. YouTube, how's the quality of the stream? Have you had any issues with it stopping and starting or anything like that? Yeah, Hoka shoes. They're called Hoka One One. HokaOneOne.com. Look at the Bondi shoes. They're fabulous. Somebody's asking about a page. Whoops, hold on. Elizabeth says, I'm way better since starting the estrogen cream. Exactly. Why? Because with estrogen, your body is producing more mucus. That is a great thing. So in case you were not at our last meeting, we do have is this the right one? Where is it? We do have a brand new magazine, the IC Optimist. Joanne says, do you ship supplements to Canada? All the time. Just go over to our store and you can ship to Canada. It's a little bit more expensive. You're going to want to do priority mail international because it's trackable and insured. It's going to be more expensive. but it's doable. A lot of our Canadian customers, if they live close to the border, they have a US PO box and they just drive over the border to get their magazine, and it might cost $5 to ship the supplement to them. But if you're deep in Canada and you don't have that opportunity, then you're probably going to be using Priority Mail International, and that's going to add $20, $25 to your shipping fee. So get what you need at one time so you don't, you're not paying extra for shipping. Lauren says, is there a connection between tooth decay and Elmeron? Not that I know of. There's a connection between tooth decay and dry mouth and certain medications common to IC, like antidepressants, Vistaril, Atarax, antihistamines, Elavils, amitriptyline, things like that. Lauren said, let's see. Elizabeth says, thanks to you. I'm so glad. Kayleen says, I'm just jumping in here, but I was finally diagnosed with IC. Well, I hate to say congratulations because nobody wants this diagnosis, but I'm glad you know. I'm glad you have some knowledge and you know now. And now what we got to do is figure out what variant of IC you have. What is your presentation for IC based upon our subtyping system? Hunter's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, or central sensitization. And you can learn more about that over on our website, icnetwork.org. Kathy says, does estrogen cream help build the bladder wall? What? No. Estrogen cream gives the bladder cells what they need to produce a better bladder wall. Estrogen doesn't build a bladder wall. The body builds a wall. Estrogen is a critical ingredient for the production of mucus. Marina says, what's your opinion on biofilms and its treatment? Biofilms are, you guys, 40 years ago, my senior project when I got my pharmacology degree was the isolation of drug-resistant bacteria in hospitals around UC Santa Barbara and around campus. We didn't know about biofilms back then, but what we know now is that bacteria often live in group colonies. And what's so interesting is it's not the same bacteria. It's a heterogeneous population of bacteria living together, and they excrete this rigid coating to protect them. That's called the biofilm. It's a filmy cover, but that film is so rigid that antibiotics cannot get through it, and it even survives heat sterilization autoclaving. How crazy is that? I mean, that's just so crazy. And what's even more interesting about a biofilm is when you break it open and you look at it as a researcher, it's even arranged in a very, very interesting way. It's arranged with certain types of bacteria in the middle, certain types of bacteria along the edges, and it's absolutely fascinating. So research right now is struggling with the concept of how do we destroy a biofilm. But here's the problem. Biofilms are supposed to be there. I mean, they're in every body of water we have. So the assumption that a biofilm is always pathogenic is, I think, a terrible mistake. Because it is a natural habitat for good bacteria as well as bad bacteria. And so the question is if you systemically take a medication which destroys all the biofilms in your body, how is that going to disrupt your biome? And is that potentially going to release bacteria somewhere in your body where it's not meant to be, like your brain? And I remember reading a study like 2 years ago where they said, and God, don't quote me. I mean, I know this is what I read when they were talking about biofilms in the human body, that there were some biofilms in the brain. They talked also about dental work, that you can find dental pathogens throughout the body, including in the brain, because that pathogen gets into your bloodstream, et cetera, et cetera. So there was some concern that perhaps a biofilm is meant to deliberately contain bacteria and keep them safe. I mean, it's just so interesting. We just don't know. But if you've got a biofilm in your brain of pathogenic bacteria, then this is how your brain is isolating it, and you release it. What is that going to do? We just don't know enough yet. We don't know enough yet. The assumption that all bacteria is bad is foolish, because we have billions of bacteria in our body that help us function. As an example, the cells that line the bowel only eat one type of food, and it is a food that the human body does not make. It is a food that a specific species of bacteria makes. And that is what keeps the cells lining our bowel healthy. And if you take an antibiotic and you kill the food source, then you're not going to have the food that you need to keep your bowel healthy. And those cells are going to die. So this is a great, I mean, if I could go back to grad school, if I wanted to be working in a lab, that's exactly what I'd be working on. I would also be working on nanoparticles. Joanne says, I'm in Central Alberta. Thanks for the information on shipping. Learned a lot from your session. Thank you. Elizabeth says, I need a plant-based estrogen cream. I use Bezwecken, but they changed the ingredients. Not my specialty, hun. Catherine says, do you recommend we take probiotics? If there's one group of patients who have been completely compromised through the overuse of antibiotics, it is us. It is the lower urinary tract patient. I was on antibiotics for years for what I now know is probably a tailbone injury. That did irreparable damage or harm to my gut, which would explain why I ended up with really severe IBS. And now that I haven't taken antibiotics in 20 years, except I'm sure they gave me an antibiotic shot during my hysterectomy, right? And it's so interesting how I'm so much better. Like, I haven't had an IBS attack in ages, years. And I rarely flare. I rarely flare unless I'm under acute stress. Then you're going to see me in the bathroom peeing and pooping all night. Tell me I got to get on a plane tomorrow, I will be up tonight peeing and pooping in the bathroom. It's what it is. Jay says, the audio on YouTube is breaking up for quite a while now. How is it now? Testing 1, 2, 3, testing 1, 2, 3 on YouTube. Because you're on this microphone. I didn't know what to say. Anne says, I've been getting constant UTIs. My urologist also said I should be using estrase cream 3 times a week. That should help. Your urologist is absolutely right. There is absolutely a group of patients, usually women, usually older women, or women who are postmenopausal, who get recurring infections. Like every week, every 2 weeks, every month, bam, there it is again, E. coli, again, over and over and over again, easily identified. And I attended a class on that, taught by Dr. Anthony Schaefer at the American Urology Association about a decade ago. And he made a couple of really important points. He said, number one, these patients are never told they have a simple UTI. They're always told they have a complex UTI. Number two, in the research they've done, what they consistently found is that about 24 hours before the bacteria arrives in the bladder, it's living quite happily in the vagina. And so the vagina has kind of become being the seed source, right, for the bacteria. And so that led the researchers to ask, well, wait a second, what has happened to the vaginal defenses? Why has the vagina become a safe haven for bacteria? And the answer goes right back to estrogen atrophy. So for these women, in addition to being given antibiotics, they're always usually going to also be given an estrogen cream so that you can give those cells what they need to produce the mucus in there that will make it much harder for bacteria to infect you. All right, you guys are saying the audio is good. Awesome. Lauren says, my dentist is saying I need to have all my teeth removed because they're falling apart. He said it was medication-induced tooth loss. Girl. I haven't seen that happen in the IC world. I mean, I will say again that if you're on a lot of antidepressants or a lot of antihistamines, you're going to have very, very dry mouth. And remember, the moisture in the mouth is just as important as the moisture on the vulva and in the vagina and in the urethra and bladder. And so if you're struggling with super, super dry mouth, what that means then is that you're going to get cavities. The bacteria are going to reach tissue that they normally would not have reached. You could end up with periodontal disease because of that. It's really important when you have dry mouth that you use dry mouth products, like Biotine, Biotine gum. There's a dry mouth gum, Xylamelts, or this is what I use. Although I don't really have dry mouth so much anymore, but these are just little. These are just a little pill. They've got a brown background. It's kind of hollow, and you can like put it right on the inside of your lip, and it will stay there for hours, and it will just trigger the release of mucus. I don't need to do that while I am talking, though. Hold on. I also use a little piece of wax because I got a hole between my lower front teeth. I know you can't see it. There's an edge there that just drives me crazy, so I have to put wax on it. And my wax just fell out. So hold on a sec. You don't need to see this. I will turn my back. Okay. The hole is filled. Alrighty. What Kayleen said, would estrogen help vulvodynia? Absolutely. Absolutely. If your vulvodynia is caused by dry skin, estrogen cream is the way you fix that. You can also use coconut oil, other stuff like that, but it's really the estrogen cream that's the most important piece of that puzzle because your body uses that estrogen to produce natural mucus. Sylviane says, I'm wondering what supplement would be better for me, Cystro Protec or Bladder Builder? Well, you cannot get Cystro Protec right now, and you probably won't have it for another month or 6 weeks. So Bladder Builder is available. The difference between the two is they're very similar. They have chondroitin and glucosamine for bladder wall protection. They have quercetin for an antihistaminic effect. But Bladder Builder takes it one step further, a couple of steps further. It's got some beneficial probiotics in it, but it has an ingredient in it called palmitoethanolamide, which helps reduce pain. And so if you have a component of pain to your symptoms, Bladder Builder would be a better choice because we have research that proves that palmitoethanolamide can reduce IC pain. And we talk about that on the website. So to me, in my opinion, Bladder Builder is the superior supplement because it also actively treats pain. We just did our 1-year follow-up study with Bladder Builder last summer. 60% of the patients who tried it loved it, and they're still on it today. They have some of those patients, 20 to 25%, are now pain-free on Bladder Builder, which we were thrilled to see. The others are reporting lower levels of pain, fewer flares, shorter flares, less painful flares. 40% of the patients who tried Bladder Builder didn't like it. It was either too expensive for them, the doctor wanted them to do something else, or they had a gut-related side effect. Any of the supplements have the potential of giving you gut-related side effects. Helen says, is it safe to have iron with a vitamin? I don't see why not. I mean, especially if you're anemic. I mean, my mother has IC and vulvodynia. She takes iron pills every day. Lauren says it's not cavities, it's tooth decay, but I didn't have but one cavity. I'm thinking it may be caused by pain medication that dissolves in my mouth. Anyway, well, cavities are tooth decay, hun. Cavities are bacterial tooth decay. So maybe you've got something else that is causing the calcium to break down in your teeth rather than a cavity. I'm so sorry you're going through that. That absolutely sucks. That sucks. Brita, thank you so much for the stars. I really appreciate that. Thank you for sending me 150 stars on Facebook. Okay, so normally what we would do at this point in time is we go into our Zoom meeting, and I think we're going to do that. I am just a little bit out of it today because of my TMJ and all the meds that I'm on. So hold on a sec. I had a lady from Scotland email me. She wanted to come into Zoom. Does pelvic floor Botox injected it through the vagina cause urinary retention? It can. It can if it numbs nerves involved with urination, or if it leaves the muscles in a state of contraction, I guess. Hold on, let me find this. Somebody asked, does vitamin K12 irritate the bladder? No, not usually. Somebody else is asking, no, that's. Learned something interesting this week, and that is that if you are taking warfarin, you have to be very careful with any cranberry products. I didn't know that. I mean, I probably knew that at some point in time. I just didn't remember that. That was interesting. Okay. All right. Well, I'll tell you what, let me go ahead and start up the Zoom meeting. So in Zoom, this is your opportunity to come in and talk to me. Facebook and YouTube would be left on. People would be able to hear what you're saying, but they will not see you. They will not see your face. It is your choice to uh, uh, say whatever you want to say. Privacy is important. Here, hold on. I got to find the. Sorry. Okay, so to get into our Zoom meeting, all you need to do is go over to icnetwork.org, our main website. Click on support, click on streamed support group meetings. There's my face. I'm older now. And you just click on stream support group meetings and go to Zoom. Okay, so I have now officially started that stream. And let me go ahead and post the invite. Okay, so the invite. All right, hold on. Where did it go? Okay, hold on. That's Zoom. I don't need to say that in Zoom. All right. All right. YouTube, there's your invite. All right, Facebook. Give me a quick sec and let me do it on this other computer. So again, I'm going to icnetwork.org, which then goes to icnetwork.com, just so you know. Stream support group meetings. And we already have our first. All right. And let me copy this link. Edit, copy. And Facebook. All right. Facebook. There is your invite into the Zoom meeting. Richard says, does pelvic floor physical therapy really help? Dude, it's the most successful therapy ever. and we knew this in 2008, pelvic floor physical therapy is stunningly successful at reducing the symptoms that you would normally associate with your bladder. Why? Because IC is not necessarily a bladder disease. For many of you, it is a pelvic pain syndrome. And that structures outside of the bladder are victimizing the bladder. The bladder is the victim of another problem in your pelvis. Usually, like for example, just so you know, we had a research study came out last summer that showed that 70% of the men with testicular pain, actually the reason why they had testicular pain is because they had a problem with a hip. Jill, that was hysterical. That was hysterical the way you did that. It's always nice to meet another Jill. All right. So for those of you on Facebook, for those of you who are on YouTube, we are now in Zoom. Please come on in if you want. And we're just going to go ahead and take it away with another Jill. Hello, Jill. It's always nice to meet other Jills. Can you hear me?
Hello.
Hey.
Yep, I can hear you. How are you?
I love that color on you. That is beautiful. She's wearing this gorgeous purple sweater.
Thank you.
How are you feeling? How is life?
Well, life at IC is hard, right?
It can. It certainly can be. Definitely. What's going on?
I've had IC for a really long time.
Okay.
So.
Oh wait, you muted yourself. Wait. There you go. Okay, and then hold on, Caden. I have to unmute Caden. I got to mute Caden. All right. Oh wait.
All right. So I had IC since I've been 23. I've never had a remission. So I've been managing my IC with bladder installations at Beaumont Hospital in Royal Oak.
Okay.
And antihistamines, H1 and H2 blockers. They make my life like bearable. So I also have I was born with my hips out of joint. So I have pelvic floor dysfunction too, which kind of adds to that party.
Yeah.
So I never ever, and I have endometriosis, right? So I just never get a break from any of it, really.
So how old are you now?
50.
Okay, you do not look 50. Not even close. Not even close. So you are one of those wonderful anatomical mystery patients, especially because your symptoms began at such a young age.
Mm-hmm. They started after a bladder infection, and they gave me ciprofloxacin.
Okay.
And I have hypermobility, and I think it probably hurt my bladder wall, is my theory, but I don't know.
I mean, so you're seeing Dr. Peters, right?
Yes. Well, I see Dr. Peters and then his nurse, Stephanie Spanilow, who is she's new. She's new. It used to be Kate.
Yeah.
And Kate took a promotion to full-time mom, so she's home now. But
nice.
Yeah. So I have really good care. But I don't get full relief. I just don't. So
for those of you listening, Dr. Ken Peters is one of the top IC doctors in the world. He practices at Beaumont Health in Royal Oak, Michigan. He's generally where we refer patients from Canada who are coming from Canada, or if you're in the Midwest. What makes Dr. Peters really one of the best is, number one, he is meticulous. He is a meticulous surgeon, which is why he's literally probably the best interstim surgeon in the world. But he has an incredibly open mind. He doesn't walk into any room with a strong bias where it's like, I'm going to make this treatment fit this patient. Instead, he's going to focus on finding the right treatment for the patient, right? And so you're in really, really good hands. But what makes your case all the more interesting is something called the somatovisceral reflex. So you said that you were born with a birth defect and that you had a hip problem.
Yeah, I also have like spina bifida occulta.
Okay.
Like like it's it's probably like a combination of nerve and the antihistamines really help, help,
Okay.
but with the pelvic floor dysfunction and there's just a lot going on, and the endometriosis is just hormonal
Right.
disruptions. I just had it's been kind of misery for the whole time, and
So,
I never really had good care until I found Dr. Peters in
right,
the Beaumont
right,
Hospital.
right.
So
Okay. So have you dreaded going to the OBGYN your entire life because you knew when they put the speculum in it would hurt?
not so much. That is not such a problem now because I have had several rounds of the pelvic floor PT with the Beaumont specialist.
Okay, but before you went to Beaumont, were you
Yeah.
okay? Was sex always uncomfortable for you before you went to Beaumont?
It didn't really become uncomfortable until I was like probably 27. I had an ovary that adhered to my abdominal wall.
Okay.
And then I had to have a surgery to, get that off because of and then they did the ablation of the endometriosis. And so about that time period, that's really when everything just took off. So I don't think I really would have called sex uncomfortable until I was almost 30.
What are your symptoms today? What are you struggling with from a symptom standpoint?
Today I'm having like I have a psoas syndrome going on because of my hip slide slipping.
Okay.
And so that has everything kind of in a upset state.
Absolutely.
So, and I have degeneration because of my hip instability all my life. I have a degeneration between L4 and 5.
Okay.
That is kind of took off in the last month. And so it's just kind of a mess.
Okay. So let's do a little anatomy lessons because the real big question is chicken or the egg, which comes first, the chicken or the egg, and that's really, really important for you because we know that the bladder and the pelvic floor are intricately connected. They don't function in isolation. So you could have legitimately had a bladder wall injury from a chemical and your pelvic floor muscles will get tight. That's guarding, right? I don't think that's you though, because you were born with a variant of spina bifida and you were born with a host of muscle problems. So what is the legacy of those muscle problems? It's called the somatovisceral reflex. In the somatovisceral reflex, the question is can muscles change the way organs behave? Now, so the viscerosomatic is the opposite reflex. Can organs change the way muscles behave? And the answer is yes. Anytime you're in pain, your muscles are going to get tight to protect you. So we know absolutely that organs, especially a sick organ, is going to make muscles dysfunctional and tight. But the reverse is also true. Can muscles change bladder behavior? And the answer is absolutely. Absolutely. Because when you have a tight muscle, the first thing that happens is reduced blood supply. Ischemia. And so what that means then is that the bladder might only be getting 70%, 50%, 30% of the blood supply it would normally need to be healthy. Okay. And so long-term ischemia, and there are some doctors who believe that this is all ischemia for everyone. And again, I don't believe in all or nothing statements, but ischemia is real. So I would have to wonder if literally from the start, your hip abnormality created long-term, constant, chronic muscle tension. The legacy of that is that the bladder wall and the bladder itself is not being delivered the oxygenation and nutrition it needs to be healthy. The other legacy of that is that tight muscles also restrict the nerves that support the blood supply that supports the nerves. If the nerves don't have good blood supply, they stop functioning correctly too, and they become what we call maladaptive, and they become more sensitive, they become more vulnerable, and that sensitivity then spreads. It starts at the bladder, it goes up to the spinal cord, and then it goes and affects, that's what we call allodynia. It can affect other proximal nerves. So
I feel that way. Yeah. I feel like I just like if one thing is off, everything is on fire. If that makes sense. And so there's almost there's not a day that goes by that I'm not having pain because of some reason or another, because if it's not the endometriosis, then it's the hip. And if it's not the hip, then it's the pelvic floor. If it's not the pelvic floor, then it's the bladder. And, and then I have fibromyalgia, probably because, everything is just all, so I don't go a single day without a lot of pain.
Okay. And you're right about the fibro. The fibro happens because the nerves in the area are traumatized. But there's one thing, the one thing I want you to remember from this conversation more than anything else is this is not your fault. You have done nothing wrong. There isn't, I can see that in your face. You're feeling a little bit like it's your fault. Honey, I know it's not your fault. You have done nothing wrong. You were born with an abnormality in bony structures, right? You had a little bit of spina bifida, you got a little bit of hip issues too, and that's going to affect how your muscles are functioning. And so, number one, I need you to give yourself a giant hug. You for everybody who's watching here, this is a hero. Jill right here has lived for years with pain. And yet here she is smiling. She hasn't given up. She's trying to learn as much as she can. And you are the perfect example of a woman who will stop at nothing to try to get better. And again, the great thing is that you're in absolutely great hands. The question is what do you do first? And it's not that easy. What we have to do is create an environment in your pelvis to support healing. And that begins first with oxygenation. The blessing in this entire thing is that you're already improving that. You're already doing the pelvic floor work. And you're going to have to keep doing that. And you're going to be doing that for the rest of your life, hon. Just like I'm going to be doing that for the rest of my life. What I want you to do when you go to your pelvic floor physical therapist, and even with Dr. Peters, I want you to, so I'm assuming that the muscle tension comes back quickly.
Yeah, it does. And I have to do it. I do the pelvic floor PT, the internal pelvic floor PT every other day. It has to be done.
And they're doing it. Are you using a wand on the off days?
I'm using it. No, I'm finished with the PT because I've done 2 or 3 rounds at the Beaumont. And so I do it now. I do it on my own.
Okay.
But I do it. It has to be done every other day. It just has to be.
Okay. So to me, the next question is why are your muscles consistently tight? And can we do anything about those bony structures? Are they saying anything about your hip? Is there anything that they can do to try to restore hip function?
Well, I do Tai Chi, and that has helped for a really long time, but I'm not sure why. But recently, in the last couple of months, my hip has I did for a long time prolotherapy on my sacroiliac joint to keep it stable. But it has destabilized. So I'm back to my neurologist and his physical therapist to try to fix the hip again.
Good.
So that's kind of it hasn't been as much of a problem until recently. So hopefully we can get that back to baseline.
Okay, but honey, this is COVID. This is being at home. This is sitting for long periods of time.
I think that's what it is. I think what happened actually is I got the vaccine, and I would never. I'm not telling anybody that they shouldn't get the vaccine, because I think everybody should get the vaccine. But I am sensitive to vaccines, so it did put me in bed for a few days after each vaccine.
Okay.
And I think that in addition to the being less active because of COVID, having those 3 days, 6 days really total, I think it probably just threw me off. And I think it might have started a little bit of an inflammatory process that I have to deal with.
So I have scoliosis, right? And I know for me, the more I lay down, the more pain I get, especially in my psoas muscles. There's some days where I'm wearing 3 heating pads down my left side, because it's my left side that gets tight. So I need to be up and moving around. And COVID has been devastating for those of us. We can't go to the gym. We haven't been able to walk comfortably. I mean, there are just issues. Listen, you need this. You need this book desperately.
Well, I'm trying to see the title.
Breaking Through Chronic Pelvic Pain.
Okay.
This is a master class in pelvic anatomy, muscles, bones, nerves, etc. But the reason why this is so important is because Dr. Weiss, who is a pelvic pain specialist who started out as a urologist, he saw very early on that bladder therapies didn't help. And he became a muscle bone specialist. It's like, what else in the pelvic cavity can be causing these issues? What baffled him is, why did the tension come back? You could walk into his clinic with trigger points and tight muscles. You would walk out with the trigger points resolved. Why did it come back in exactly the same spot? And that's when he said, okay, we have to look at bony structures. We have to look at those things which put pressure on those muscles. And that's why you need this book.
Okay,
because
write it down
this book is gonna help you look at any and every muscle structure, bony structure that could be triggering your long-term muscle tension. Your SI joint. I would want to know the health of your SI joint. I would want to know the health of your tailbone. If your tailbone was ever broken and healed out of position. I would want to know how you're walking. A good physical therapist is going to have you walk down a hallway. They want to see if you're favoring one side or the other, or if you've got one leg longer than the other. But the most important chapter in this book is actually the chapter on the feet. That in his clinic, for his group of patients who are dealing with long-term chronic tension, the great majority of them had foot abnormalities. They were not walking correctly. And when they got their walking fixed, because when you walk, all those stresses are referred right back up your legs into your pelvic cavity. So if you've got one leg longer than the other, then you're already walking at a disadvantage. You already have uneven hips. But if you've got an ankle rolled inward or an ankle rolled outward, or if you've got Morton's toe or Morton's neuroma, that is going to affect your pelvic floor. And so the cure or the healing for those patients with long-term chronic muscle tension was to restore proper bony structures, especially in the feet. And they were able to get them out of chronic pain because of that. So to me, I don't know, and you don't know, we've got a guess. We know you've got a hip abnormality. You should look at this for that reason and really think about your symptoms and think about those structures so that you can then have Dr. Peters look at those more closely, or maybe go to a physiatrist or the neurologist that you're seeing.
Yeah, I see Dr. Kovar here in Michigan. He's a DO.
Yeah.
And he is excellent at that. He really set me back in place. And when I was about 35, I had an ectopic pregnancy rupture. And when they cut my, when they did the laparotomy to save my life, they had to do it fast, and they really, destabilized my hips and joints. And he really saved my life until recently. I mean, this
Yeah.
is kind of back again.
Yeah, but you know, again, it makes total sense. I mean, who watching this is not at a worse place today than they were a year ago because of what's happened. Our stress levels are higher, our anxiety levels are higher. We aren't able to exercise like we used to. Pretty much all of us have gained an extra 5 or 10 pounds because of that. I certainly have. And then we're lonely. I mean, the loneliness is real. It's real for us right now, and that's gonna take a toll on all of us. But to me, I think the most important thing here is that you can't pick and choose. I'm going to do this and not this. Everything is completely interconnected in you, and it's ultimately it's going to come right back down to bones and muscles. And I think that your bladder is the secondary victim of the bony structure and muscle issues. And of course the endometriosis is a whole separate beast entirely that comes from chemical exposures now. And so making sure, if you can, join the Endometriosis Association. They're a fabulous nonprofit. They're the ones who helped us make the link between endometriosis and dioxin and industrial chemicals. Now we know why endometriosis is present in millions of women. It's a byproduct of estrogen mimicking chemicals like dioxin, which cause this tissue to grow. So you really have to get rid of all the chemicals in your home. That's so incredibly important. But I think you should. I mean, you've got far more blessings than you have negative things going on right now because you're already under the care of one of the best doctors in the world.
Yeah, I feel really fortunate to have found them.
Yeah,
because they really are like.
They're outstanding.
Amazing.
Yeah.
Yeah.
You just can't focus solely on your bladder. You got to look at the totality of your pelvis. And again, you got to get rid of the shaming and the blaming. You know, none of this is the result of anything that you've done.
Yeah.
And I think, go ahead.
I was just going to say, I'm an Agent Orange baby too. Like, yes. I was born after Agent Orange exposure in Vietnam. So like, that's the dioxin.
Right.
And plus I live in Michigan where they had dioxin in the milk for a long time. So without knowing it. So like all those things are not good.
I think that for patients like you and like me, because mine is similar in that we have the early onset in childhood, is I'm still dancing this dance of anger about it. It's like, you know, I just wanted a normal life. I just wanted to be able, in fact, I talked with an old friend from high school a couple days ago. I hadn't talked to in 10 years. And I told her, I said, you know, I always envied you because you could walk into any room and feel comfortable and feel happy and you didn't have to worry about bathrooms or anything. Whereas when I was with her, I would walk into the room, but where's the bathroom? And I would be in the back. And I will say that it's something that I still think about a lot, that I don't let it get in the way of what I'm doing. In fact, it inspires me to keep doing what I'm doing so that I can tell you, you didn't do anything wrong. But I'm kind of pissed off about it. This isn't what I wanted. This isn't what I wanted.
I worked really hard for valiantly to have a normal life.
Yeah.
Like, you know, I mean, and to work, like I worked full time up until I just recently went off on disability because I just, you know, my health just collapsed at a certain point. You can only work through chronic pain for so long at full speed.
Yeah.
And so I tried very hard.
But there are moments where you get to come first. Yeah. And if going out on disability helps you come first and take the time to get back into restoring good muscle health, calming things down, stress, you know, reducing stress overall, power to you. That's exactly why disability exists, to help us get through difficult moments when our body isn't cooperating. Again, no shame or blame. If you got to do it, you got to do it. Embrace it, do it, dive into the medical care that you need, get back into the muscle work that you need. And I think you're going to find this book just so incredibly eye-opening, and it will really help you connect the dots. Okay.
Okay. Yeah. I'll get it. I appreciate it.
Okay. Well, listen, if I could give you, this is the new hug. I'm giving you the new hug. Right?
Thank you.
This is the BTS hug. You know, you are not alone, my friend. You're not alone, and you look beautiful. And
thank you.
Carry hope in your heart every day. Every day it's a new day with new opportunities for healing and all that sort of stuff. And you know who to call if you need a pep talk. Okay?
Thank you.
And when you see Dr. Peters next, tell him Jill at the IC Network said hi.
I will tell him.
Okay.
I don't know how I lost your picture. Okay.
Okay. See you later.
Bye-bye.
Okay. We're going to go to Flower next. Flower, can you unmute yourself? Of course, there's always a chance that people are in the bathroom. Flower. That's her name on Zoom, his or her name. Flower. Flower. Okay, if anybody else would like to come into Zoom, let me, the invite is in there, but let me, Flower, hey, you're unmuted. Are you there? Flower. Okay, you did unmute yourself and you have your camera on, but I can't see you. I can see distinct movement. It's like looking through frosted glass.
Volume level 7, alert expanded.
Hello, Flower.
Hi.
How are you, girl? How are you doing today?
I'm doing fine. Thank you for asking.
What can I do for you?
Oh, you already answered my question. It was about, I had a CT scan done with one with and another without contrast because my IC was acting up, but they thought I might have diverticulitis.
Okay.
But it came back I did not. But
Good.
they said I was severely constipated in the large colon.
Okay.
And you said that one of the symptoms might have been I was dehydrated.
Yeah.
I don't understand that. I drink water like this.
Well, okay. So I want you, Flower, I want you to think about it this way. Think about
Dialogue.
your
Cancel. Button.
I don't know
Loading complete.
There's a mechanical noise, a computer speaking. I don't know what that is. Okay.
Yes, I've lost you.
Okay. Can you hear me now?
I can hear you, but I can't see you. But that's okay. Go ahead.
Okay. So your intestine is a tube, right?
Yeah.
Starts at your stomach, ends at your rectum.
Right.
And the way the intestine works and moves things along is by squeezing, right? It's called peristalsis. We have gentle waves or gentle pain-free spasms that move food down the tube.
Of course.
And generally, the way it works is a food in, poop out approach. That when you eat a meal, you stimulate contractions to let poop out. It's about making room, right?
Untitled
So, okay.
More pages. Profile 1. Microsoft Edge window. Volume level 72.
Oh wait, hold on. We just lost our camera. Facebook, we just lost your camera there. Do you have Microsoft Edge open?
I don't know. I can't see.
Yeah, it's whatever's happening is happening on your end. It's not happening on my end.
Okay, but I can hear you fine.
Yeah, I know, but it's like something is trying to translate what I'm saying. Okay, well let me just try. Okay, and for everybody that we don't know about the computer noise, so it is what it is. The way that the bowel works again is a food in, poop out approach. Yes. So question number 1 is, what makes food move along? It has to have something to push against, right? If you were just completely liquid, and you had no solids in your bowel, nothing would move. It would just be squeezing, and the liquid would go back and forth, back and forth. So our food deliberately has fiber in it for structure, that when there's structure in our bowel movements, it can push against it and move it along. Okay, so concept number one is fiber. But for fiber to be the most effective, it needs moisture.
Of course.
So think about dry cereal. Dry cereal, you can't even imagine that moving. But when you put milk on cereal, it softens and it's much easier to chew, but there's still structure. So in your bowel, something has gone wrong. You either do not have a good gastrocolic reflex or peristalsis, and food is kind of the stool is stopping in your large intestine, or it's dry, it's not moist enough, or you're not eating enough fiber.
Okay.
And it's that magic combination of water and fiber. And not to be grisly, but we can be grisly. There's no shame. There's no shame here.
Right.
When you do have a bowel movement, is it hard marbles?
Sometimes.
Right. So hard marbles means not enough fiber, not enough water.
Okay.
Take it from somebody who's been there.
Absolutely. Okay. Well, the reason for all this was my stomach started hurting, and I've had IC for about 15 years. And
Catherine McHenry has joined.
I've never had any problems until.
Go ahead.
22.
And the doctor thinks that's what was doing it.
Okay, I lost that. Say that again. Your doctor thinks it's doing it because what?
Because I was so stopped up, it's causing my IC to push against my bladder.
Oh yeah, definitely.
Causing all my problems.
So
if I start taking more fiber and obviously drinking more, then the burning and the pain will let up, right?
Sure. But
Okay.
I mean, I would assume that at this point in time, you're probably in enema territory.
I am.
Yeah. No, girl, I've been there. I've been there. Who hasn't been there?
First time ever.
Yeah. And so that might be the direction that you need to be, just to kind of get things moving, because it takes a couple of days for the food and the water and the fiber. You want to do soluble fiber. Soluble fiber is more gentle on your gut. And so things like oatmeal, not granola. You don't want to do a hard granola or grape nuts. You want to stick with a soluble fiber. We sell 2 different soluble fibers, and I'll show you the one I use. Where is it? Here it is. Heather's tummy fiber is fabulous. Absolutely fabulous.
Right.
And this is a completely soluble fiber, dissolves. I have it in my coffee. I mean, not my herbal coffee, not real coffee right now.
I can get down your store.
Yeah.
Henry at the meeting. Volume level 72.
You know what? That is on my end, and I have no idea how that happened.
But I can buy that in your store.
And then regular girl is also a viable option for you. Okay.
All right.
So
now, is this something I should take every single day?
Yeah.
Or?
To have good normal bowel function, you need to be eating between 20 to 25 grams of fiber per day.
Okay, because my diet's always been lots of vegetables, protein, and I do the best I can on the fruit.
Volume level 72.
Yeah.
I just wanted to say, like, I used to have really horrible IBS and terrible, like, alternating constipation and diarrhea. And one of the things that I did that helped is I did an elimination diet, and that I was very sensitive to dairy and red meat.
Mm-hmm.
Oh.
Dairy and red meat out of my diet, and I upped the amount of cooked. Like I couldn't eat. I still can't. I still cook almost everything I eat. I don't even fruit. I don't have raw. So like
Okay.
cooked my vegetables. I upped the amount of vegetables I had. I upped the amount of water that I drank, and I cut out the red meat and the dairy. I over time I healed my bowels. Like
Yeah.
it healed. And now one of the things I use just by happenstance is if I'm having trouble with constipation, this is like well down the road, like after you use the soluble, you're done with your enemas and you've changed your diet, your bowels have healed. Magnesium can really help.
Okay, I do take magnesium.
Yeah, that can help with regularity later on, but
Okay, all right.
you still have to. You start exactly where Jill is saying. You're starting like with the soluble fiber and enemas and stuff, but I felt like the elimination diet was like, because I've had so many long-term problems, like it was life-changing to just find out that if I eliminated dairy and red meat, that I had, I eliminated one of my problems, which
And I have to second the elimination diet. And for me, now I can do red meat, but I don't do a lot of dairy. I do mocha mix and I do coconut milk ice cream and things like that.
I do coconut milk, yes.
But the foods that triggered my IBS were chocolate and oatmeal and green salads. So I don't eat oatmeal because I spasm violently when I eat oatmeal. I don't eat chocolate, and I don't eat lettuce. And lettuce is notorious for triggering IBS because lettuce actually has pretty rough edges that are quite sharp and irritating.
And that's something I eat every single day of my life.
Yeah. I used to, but I used to have issues. So that's why the elimination diet is so useful.
Yeah.
And generally, the first thing they have you do is lose dairy. The second thing they usually have you do is stop your grains for several days, except maybe rice, and then introduce them back one at a time to see which grains are working. I get very bloated and gassy with any white flour product. And so I have tried to avoid all white flour. I eat Ezekiel bread rather than white bread.
Me too.
Yeah. But you still got to add up. You have to add up your daily fiber intake. I mean, 2 pieces of Ezekiel bread is, I think, 6 grams of fiber. You need 25 or 20 to 25. And lettuce does not have a lot of fiber in it. But a serving of green peas has a ton of fiber on it.
I just read that yesterday. I did not know that.
Yeah. So 13 grams of fiber versus 1 gram of fiber. So just like I really love Taco Bell burritos, just plain beans, burritos, a flour tortilla, even though it's a white flour tortilla, beans and cheese. Boy, throwing in, but I also make my own burritos at home a lot too. But just making sure that you're having a good serving of green peas or beans every day or every other day is life-changing when it comes to the bowel. Life-changing. Okay.
And you say that this has nothing to do with gluten?
Well, IC does not. So IC has not been formally linked to gluten intolerance or celiac. Okay, but there are
volume level 72.
I do not know why my computer is doing that. I am so sorry. My computer a voice keeps coming in. That I don't know what that is. Okay. Well, anyway, what was I saying? I lost track. I'm sorry.
We're talking about gluten.
Oh, I know that when even though I tested negative for celiac disease, my body does not like white bread or anything with gluten. I'm much better gluten-free. And so that's something that you can experiment. I don't eat regular pasta. I eat quinoa pasta or corn pasta or rice pasta. It's I rarely eat white bread, but I will every now and then. And my favorite is a cinnamon roll, and so I will do that. But if I did it every day, I'd be bloated I would be huge.
Oh yeah.
The bloating is real with gluten for me, and so I would.
That's what cabbage does to me. Yeah.
Yeah. So I would play with that a little bit, and then come on over to our website and look at our section on a diet and on fiber. And again, the Heather's Tummy Fiber, I swear by. I use it every day. I love it.
I'll have to try that gel, and I so appreciate all this.
You're very, very welcome, my dear. You are not alone, and thank you for sharing.
Oh, you're welcome. Yeah, a good rest of your day.
Okay, you too. Bye-bye now.
Bye now.
Closing tab. Post attendee. Zoom untitled and.
All right, so we're going to go to Catherine. Catherine, can you unmute yourself? Catherine, I see you in here, but you need to unmute yourself. Now, she might have taken a potty break. That's okay. So let us wait for her. And let me come back to your questions here. Helen says, correct. Is it take to safe iron with vitamin C? I'm not sure. Hello, Catherine.
Hello.
How are you? How are you feeling today?
I'm good. Sorry, my internet is a bit off.
Well, what can I help you with? Catherine? Nope, you have muted yourself, hon. I'm going to ask you to unmute. I can't hear you because you somehow clicked your mute button again. Nope, you almost had it.
Hello?
There you go.
Hi, sorry about that.
Okay, hon. Well, what can I help you with today? How are you doing?
I'm okay. How are you?
I am a little out of it because I actually almost dislocated my jaw yesterday. And so I've got wicked TMJ right now, just wicked. Life, right? I mean, if it's not one thing, it's another.
I know it's a lot.
Yeah. Well, how is your IC?
Right now it's not good.
Okay.
It started actually, like, I've had chronic UTIs since I was 20.
Okay.
And I've had chronic UTIs since I was 20, and I always would just take antibiotics, and after a few days, I would be fine.
Okay.
Then in December, it didn't feel like a UTI. It felt different, but I assumed it was something like that. So, but then I just kind of left it. I didn't do anything for a few days, and then I went to the hospital because it was getting worse. And they gave me my usual course of antibiotics, but I wasn't getting better. And then they gave me, I had to go back, and they gave me antifungal and more like a stronger antibiotic. And after I took the antibiotic, I felt better.
Okay.
And then it came back a few days after I stopped the antibiotic. So that was in December. Fast forward to now.
Okay.
I've like eliminated a lot of my diet, and I've actually lost like quite a bit of weight from it, which is kind of a concern because I really want to keep weight on.
Okay. So how old are you now?
36.
Okay, and this started for you in your early 20s.
The UTIs, yes.
Okay, and are you sure it was a UTI every single time? Did they always identify a bacteria or not?
No.
Okay, so you just thought it was a UTI because you had frequency urgency pressure pain.
Pain. Yeah.
Okay.
Sometimes I know it was UTI because I would have like real burning and blood. But then after the UTI, I always like, even after the UTI, I would have like some lingering pain. And then during my pregnancy, I had what I thought was UTI, but it was just pain and there was no infection.
Okay.
But it resolved.
Okay, so you have to remember that the bladder only knows one language: frequency, urgency, pressure, pain. A bullet wound feels like UTI. A stab wound feels like UTI. Cancer feels like UTI. Injury, chemical injury feels like UTI. Pelvic floor injury feels like UTI. That's the only way that the bladder can communicate that there's a problem. All right. So let's go back to when your symptoms first began and tell me, was there any event that you associated with the onset of your symptoms?
I don't think so, but now that you were talking about pelvic pain, I was working out and I did have a tiny bit of pelvic pain, but nothing serious. It was just like, I didn't break it or anything. It was just, I was doing rocking on it, and it felt a bit sore.
Okay, so that's huge. That's huge. The devil is in the details here. The way we get a diagnosis is often through those subtle little symptoms that you know that happen. You might not think they're important, but they turn out to be super, super, super important. Okay, so so you were an athlete. You were. What was your sport?
I wouldn't say I was an athlete, but I was an avid. I worked out avidly, and I had just gotten a spin bike as well.
Okay, huge.
And I noticed that when I went on the spin bike, once I started getting these symptoms, like afterwards, I started getting pain.
Okay, there you go. So you just did it. So let me show you this picture. Okay, so you can see that this is the human pelvis, and look at where the bike seat is pushing up. Right? You can see that the bike seat pushes directly into the pelvic cavity, into nerves and muscles. And for Facebook, you guys can see that. Hold on. See that?
Yeah.
Now let's look at the model here. So let me grab the model here real quick. Oops. Runaway bell. Runaway bell. All right. So let's look at the model now. Pelvis. Right? Pelvis.
Yeah.
That's between your legs. And in fact, what's really between your legs, that's a deeper muscle we would put on, let's put on the levator ani. So look, this is a, whoops, see, my levators fall every meeting. Stay. Okay. So you can see exactly where the bike seat, when you were spinning, was pushing directly in. These are your levator ani muscles. They're kind of a triangle. These are your shallow muscles. Then they're going to push right up into these muscles, and eventually they're going to get, it could even reach some of the deeper muscles. So your triggering event was probably, if I were to bet money, and I think it's a good, now listen, my purpose here is not to make a diagnosis. It's not my job, nor should I do that. But your spinning is a huge clue, because we know you are putting direct pressure on the pelvic floor. We also know that there's something called bike rider syndrome, where you end up with muscle and nerve issues that cause pain. Now, are you still spinning now?
No, I stopped. I'm walking, and walking really helps with the pain.
So when you had have you had a pelvic floor assessment?
Yes, I'm doing pelvic floor therapy.
So when they did your pelvic floor assessment, what did they find?
They said like tissue looks good, everything looks good. which is why when I go to the doctor, of course, and they see me, everything looks perfect, everything looks great, and nothing's wrong with you. And when I asked about, what do I do about the pain, meaning like strategies, they thought I was, trying to get narcotics, which I was not. But anyways,
okay, but what did the physical?
Everything was.
It looks good, but what did she feel? Sorry. What did she feel when she
said
touched
the muscles? She said the muscles are tight.
There you go. There you go. That's it. That's it. So remember the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor. They're both involved, but one is normally driving the other. And so unless you were a massive diet soda drinker, were you drinking a lot of soda and coffee back then? Okay, so you're probably going to be in the bigger group where your symptoms began with a subtle but persistent pelvic floor injury. Your muscles, every time you sat on the bike, every time you worked out, got tighter and tighter and tighter and tighter, restricting blood flow to the bladder until the bladder itself also started acting up. But the secret here, you just said that when you notice pain when you sat down, is it the same pain?
Yeah.
Is it the same pain?
Similar, yeah.
Okay, so
it was like, and it felt like swollen, like the UTI didn't feel the same because it felt like it felt swollen.
So you need this book. You have to get this book, and it's free on Kindle Unlimited, so no excuses. You need this book. You are an anatomical mystery to be solved. And the great news here is that your tissue looks good, and you're at an age where you've got plenty of estrogen. We don't need to worry about that, but they can't see inside your pelvic cavity. And here's what we know about your pelvic cavity. Your muscles are tight.
I am finding, and I know like this relates to what you said, that now there's not enough blood flow, but because I'm finding a lot of foods are like triggering me.
Well, right. But again, that's the somatovisceral reflex, where the bladder is being impacted by tight muscles that are restricting blood flow. So of course the bladder is going to show some sensitivity, but you could be on bladder therapies for years and never get better because it doesn't solve the problem of blood flow. We got to get proper circulation in there. So and the good news again is that your tissues look great. So take that for what that means. That's great. If your bladder looks good, then that means you don't need to invest a lot of money in your bladder. You need to put your money where your fundamental problem is, and your fundamental problem is tight muscles. And, when we think about those IC subtypes, the pelvic floor subtype is much bigger than the bladder wall subtype. And again, in my office, when I do coaching with patients, you'd be stunned at the number of injuries that we find and traumas that we find. All you had to do was say workout and spinning, and that you had pain when you moved down there. That's slam dunk evidence that movement of muscles is involved. Therefore, muscles are involved. So I would double down on the pelvic floor physical therapy. And then the other far more important question is she able to relax the muscle? Why does the tension come back? That's the far more important question, is because what happens is that the pelvic.
So I feel like maybe it's that because sometimes I feel okay, and then if a certain food triggers me, then the pain comes, and I think maybe that's causing pain.
Chicken or the egg, they're both involved. But if you put all of your money in bladder therapy and you ignore your muscles, you're making a catastrophic mistake.
Yeah.
Because
I agree.
Yeah. But again, the other more important question is there anything that is driving muscle tension in your body? Do you have one leg longer than the other? Do you have a bad hip, a bad SI joint, a bad knee, a bad foot? We have to, anytime those muscles are under long-term chronic muscle tension, we have to look at bony structures. And I just want to say that this is so important, that everybody, 10 years ago, 20, 30 years ago, they were just bladder, 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 bladder. It's a bladder. And there were fights. I mean, businesses fighting with businesses and nonprofits. It's only a bladder. We're not going to look beyond the bladder. We're way past that now. Now we are doing a much thorough examination of muscle skeletal contributions to pelvic pain. And again, we had this fascinating research study that came out that showed that 70% of men with testicular pain had a bad hip. And that's showing that, and that's going to continue. We're going to see a much higher prevalence of tailbone injuries, muscle injuries, hip abnormalities, SI joint dysfunctions. And I would guess that, and that's what you got to ask your physical therapist is the tension coming back all the time? And if so, why? And have her look at the rest of your body.
Okay.
Okay.
Okay, thank you.
So we have good news here. The good news is that your tissue looks great. Run with it. Great. Good. I'm not bleeding. There's not significant trauma to my tissue. I'm going to run with that. But the pain is real. The pain hurts when I move. Therefore, it's muscle. The pelvic floor physical therapist found muscle tension. And then once you arm yourself with this book, it is going to help you tremendously work with your doctors. And when you go see a doctor, please do not walk in and say you've been diagnosed with IC. Do not do that. If you're going for a second opinion, I want you to walk in and describe your symptoms and get them to study your body. I can't sleep through the night. I get pain when I sit down that is relieved by standing. I get a vibration or a fluttering here. I get this, I get that. Your ability to list even those little tiny subtle symptoms is crucial. We need somebody to study your anatomy more effectively than just your bladder. Okay? Okay, hon.
Thank you.
It was very nice meeting you.
Thank you. You've really helped me. Like, the website's been really, really helpful, and it's been a really difficult time for me. And your website is pretty much the only thing that's been there for me. So thank you.
Oh, you're very well. I have to rewrite huge portions of it now, but just finding the time is hard. But anyway, it's wonderful to meet you, Catherine. And I hope you'll keep in touch and let us know how you're doing. And come on back and tell me what they say about your pelvis. Okay.
Okay, thank you.
All right. All right, Zoom, you guys, you were awesome. I'm going to shut Zoom down now. I'll see you, Jill. I'll see you, Flower. See you next week, okay? All right. So the Zoom meeting is ending. It is done. It is closed. All right. We're coming back to YouTube. Chimera said, what's the title? It's called Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. Okay. For anybody with any sort of musculoskeletal issue, man, that's what you got to do. And sorry, Facebook, you guys are on this different camera here and it keeps like it's crooked right now. Sorry. All righty. Okay, so YouTube is back and up and running. Well, it never stopped. It's just now I'm looking at it again. So let me move this here so that I can actually see what you're saying. There we go. All right, so let us come back now to Facebook and YouTube. Oh, come on. 214 new comments since during the Zoom meeting. Holy hell. Somebody asked about stars. Stars are a way that you can support content creators, because technically I am a content creator. And you can do that by giving me stars on YouTube, or you can come on over to the IC Network website, icnetwork.org, and become a member to get our magazine. And here is our latest magazine, the Spotlight on Men, because men often feel ignored and they should not be ignored. They have it too. And again, for them, we often find muscle and pelvic trauma as the onset or trigger for their symptoms. So in this issue of the magazine, just to let you know, we introduced the concept of small fiber polyneuropathy, which is what drives that super sensitive skin and a super sensitive bladder for those of us who have IC and IBS and vulvodynia. We also feature a wonderful interview with Dr. Elise Day, who's a urologist at Harvard Medical School. She is the next generation IC queen. I remember I talked earlier about who the next generation people are once the Ken Peters and the Rob Moldwins and the Rob Evans retire. Who's going to step up and fill that place for patients? Dr. Elise Day at Harvard is going to be one of those. She's absolutely fabulous. She did a very long Q&A with me. I mean, twice as long as most doctors would do. And the reason why it's so important is I really want you to see how IC is diagnosed today. It's very different than it was 10 years ago, 15 years ago, 20 years ago. So in this issue, we talk about the new book, Facing Pelvic Pain, which I was a contributor to. We talk about estrogen atrophy. We talk about men who have pain at the tip of their penis. Why does that happen? Men who are stuck with a diagnosis of prostatitis when it's not actually their prostate. And you know what, guys, hold on a sec. Are we cricket here? I'm sorry, you guys. We're just getting used to these everything's new right now. Okay. What else do we have here? Okay, so I can drop that down. How do I do that? What did I do? Thank you. Let's see. Hold on. Oh, Facebook. Facebook is being difficult today. I have lost your comments again. Why have I lost your comments? What did I do? Is that it? No, there it is. Okay. Gosh. Okay. What else do we cover in this interview with Dr. Elise Day? We talk about patients who are young who get symptoms, the IC versus the IBS, the multiple pain syndromes. We talk about, here's a question, the role of muscle and skeletal problems in triggering pelvic pain and IC is rapidly developing. What events or activities typically trigger pelvic floor muscle dysfunction? She says, for me, pelvic floor muscle dysfunction is always the first thing I suspect in pelvic pain. If it is not the cause, it is often a contributor. I'm like a broken record. It's very easy to examine these muscles during a pelvic or rectal exam. Anything can cause pelvic floor muscle spasms, and the person who has it might not understand the muscles are tight. A UTI, a fall, a traumatic event, a bunion leading to uneven balances of weight in the pelvic floor, a knee problem or scoliosis. A trained pelvic floor physical therapist almost always helps. And she says, with COVID, I've seen a rise in problems associated with sitting all day. It is important to protect the tailbone from strain and to pay attention to the ergonomics at the workplace, yada, yada, yada. We go over new research. We go over anxiety. We go over pudendal neuralgia and who treats that. I asked her, do you believe that IC is an autoimmune disease? She says, this is an age-old debate. Does it have to do with a lack of a connection among the cells of the lining of the bladder, exposing the nerves underneath, or is it more of an allergy-prone condition, or is it based on pain fibers in the nerves? I definitely think small fiber polyneuropathy is part of the picture, and many people with IC and autoimmune disease is associated with small fiber polyneuropathy. We are starting to learn more about these conditions. I asked her about Dr. James Malone Lee and chronic UTI, and I did ask her, do you support the use of long-term antibiotics for IC patients? She said, never, never, and that's very consistent. We talk about pain control, medications which have the most success, et cetera, et cetera. So that is the lead story in our spring 2021 IC Optimist. We do a book review for the new book, Facing Pelvic Pain. Fabulous book. If you do not understand what the hell is causing your problems, if your bladder looks healthy, but you're still struggling with symptoms, the book Facing Pelvic Pain will go over any other contributing factors like endometriosis, fibroids, Tarlov cysts, you name it. We talk about it in that book. Here's the article on small fiber polyneuropathy. Explains why we have sensitive skin. We have an article from 3 articles from physical therapists at the Pelvic Pain Rehab Center. Melinda Fontaine talks about urinary urgency, the 5 causes of urinary urgency. And we have 2 wonderful success stories for men. So Tyler's story by Stephanie Pendergrast, and Rachel Dove has another one, young man who was cured of their IC symptoms with pelvic floor physical therapy. Cure, guys, a lot has changed. We have a big interview with Stacy Hauer, the attorney who's filed the most lawsuits against Johnson & Johnson for the Elmeron eye issue. So she provides an update on what's going on with the Elmeron litigation. And of course, it is allergy season. And allergies can get worse and your IC can get worse during allergy season. So we go over that and we explain why that happened. What else do I have in here? We have a good self-help tip on, are you too hard on yourself? Of course, we all are. And then this is one of my contributions, is an article on carob for those of us who cannot do chocolate. And I'm one of those patients. You couldn't pay me to eat chocolate. Well, okay, if you gave me $1 million, I'd eat a piece of chocolate, and I'd deal with the weak cramps because I could do that. All right. So if you find if you find our life support group meeting, one of the things you can do is come on over to our website and sign up to get our magazine. This is our 19th year doing this magazine. All right. And so I truly believe, since I'm the one who writes a good portion of it and edits it, my goal is within 5 minutes, I want you to find something that you can try that might help you. I want to open doors, just like these meetings. My goal here is to open new doors for you. Okay. All right. Let's get back to your questions here. Brenda says, I've been in pain for months going to get installations. My GP did a blood test. My white blood cells were 19,000. She did nothing. Went to urgent care and they said, oh God, you have a terrible bladder infection, 4 shots of antibiotics. Why was my urologist not treating you? I have no idea, but it's certainly incompetent. On YouTube, Marina says, how efficient are heparin lidocaine installations? We call those rescue installations, and they can be remarkably successful. The purpose of a rescue is to kind of hit the nerve as hard as you can with something that will calm it down. So one of the published protocols for a heparin lidocaine installation is you do it 3 times a week for 2 weeks. So you just Monday, Wednesday, Friday, you put in heparin to coat the bladder, lidocaine to turn the nerves off, and you just keep turning the nerves off. And the goal here is to calm the nerves and get them to stay turned off. So 3 times a week for 2 weeks and once a week for 4 months, and then renew as needed. So it's helpful, but it's a step 2 treatment option. And the AUA wants you to do the easy stuff first. So, in step 1, for example, if you're still drinking coffee, drinking soda, you're wasting your money doing an install because there's no treatment that can counteract the damage done by a cup of coffee every day or soda every day. Okay, there's no treatment that can do that. So don't waste your money and pay for expensive treatments if you haven't changed your diet. You have to start by changing your diet to protect the bladder wall, especially if you've got Hunner's lesions, IC subtype 1, or bladder wall-driven symptoms, IC subtype 2. Yet we want to make sure we increase your water intake so that you're not dehydrated, which would make irritating urine. We want to make sure that we're dealing with estrogen atrophy. If your skin is dry, if you have a dry vulva and a dry vagina, you've got a dry urethra. And you got a dry bladder. So we want to deal with that. That would explain why food triggers you. And the American Urology Association says in step 1, they want you to try the supplements before you do rescue installations because the supplements have fewer side effects. And so those supplements would be the Bladder Builder, the Bladder Rest, the Cysto Protect, Cysto Renew, Cysto Mend, allopath. There are quite a few supplements that patients have used for years that might be beneficial. So, you know, the challenge with instills is you have to go to the doctor's office and they have to insert a catheter in your urethra. You're going to have maybe 12 hours, 16 hours, 24 hours of urethral irritation from the catheterization. And it also runs the potential of pushing bacteria into your bladder. And so again, that's why that's in step 2, but the other things are in step 1. So, you know, it's easy. You know, we get so desperate. We just like want and we just go to the doctor and just say, please, just give me something. Just do it. I don't care what you do. Just make the pain go away. And you can't do that with IC. You have to, again, you have to start with your anatomy and you've got to really focus on the fundamental underlying problem beneath it. It all begins with getting the proper diagnostic workup. Richard, let's see. Okay, so I'm going back down. Mary says, do stars pay, are stars on Facebook like a donation? Yes, they are, but they're not tax deductible. They're just a tip, for lack of a better term. Susan, when I was on pain meds on a regular basis, my dental problems were their worst. Many new dental issues. Sorry you're going through this. Hello, Jill. You guys are doing such a good job supporting each other. I'm just going through messages here, so I'm still 55 minutes behind because that was the time we were on Zoom. John said, is there an article that can explain to someone the pain of IC? Yeah, come on over to our website. We have a whole section on pain management and pain right on the IC network, icnetwork.org. Jacqueline saying something, she found something called D-mannose that is supposed to help with UTIs. That is true. If you have a recurring E. coli-based infection, doing something with D-mannose or proanthocyanidins, PAC, might be helpful. I'll show you the 2 that we have. So this is only if you have a proven recurring E. coli infection. D-mannose is a sugar that the human body does not use. And so when you do mannose, it is quickly excreted by your kidneys into your urine. What makes mannose so compelling is it has a receptor that E. coli binds to. And so if you've got D-mannose in your urine and you've got E. coli in your urine, the E. coli attach to the sugar molecules and then you pee them out. And so my daily D-mannose is our mannose of choice that we suggest. And then the other product is Prevent, PRVNT. And again, this is for somebody with recurring proven urinary tract infections. And Prevent is a proanthocyanidin product, a PAC product. PACs are the active ingredient in cranberry, but these are not acidic. It just contains the active ingredient combined with some D-mannose. But remember, IC is not usually infection. IC is more injury or trauma. But if you have recurring E. coli infection that come back over and over every single time, then doctors would normally give you a hormone product, estrogen cream, to improve the biome in your vagina, to make it less hospitable to bacteria. And then they might suggest Prevent or Allura, which are PAC products. And most certainly they would also suggest a D-mannose. And so my daily D-mannose. Yes, these are all available on our site. Hello, Jessica from Florida. She has a question. Has there been any movement towards a cure? Oh, Jessica, remember, I wish you were here earlier. Okay, so guys, remember we have subtypes. Not everybody's the same. IC subtype 1 Hunter's lesions are now directly related to viral infections. In fact, for IC patients who get COVID and have their symptoms worsen dramatically, we think the COVID virus is infecting the bladder. You can have a viral infection of the bladder. Is that curable? No, they're viral infections. They go silent and they come back potentially. Right? Well, we don't know about the COVID yet, but IC subtype 2 bladder wall driven. If it's a chemical injury, is that curable? Yes, because if we get rid of the chemical and stop irritating the hell out of your bladder should repair itself. So that's healable. You don't cure an injury, you heal an injury. This is about healing. For the great majority of us, there's not an active disease process as much as there is an injury process. So if you've got chemical irritation of your bladder wall from drinking diet soda or too much coffee, if you get rid of those chemicals and you calm the bladder down, your bladder should be able to repair itself. If you've got estrogen atrophy, IC subtype 2 genitourinary syndrome of menopause, that is not curable because that's aging. That's not a disease. That's just dryness. And so what do we do with that? We're going to use some estrogen cream to give your tissue what it needs to produce its own mucus. We don't cure aging. If you've got chronic fungal infection, like a candida infection, which we now know happens in some patients who are flaring, that is curable. If you've got IC subtype 3 pelvic floor driven, that is healable because that is injury. We don't cure an injury, we heal an injury. If you got IC subtype 4 pudendal neuralgia, that is potentially healable. IC subtype 5, central sensitization, chronic overlapping pain condition, small fiber polyneuropathy, that's a whole nother story because now we got nerves that are super, super irritated and we got to calm them down. Again, it's about healing. It's not an active disease process as much as it is a nerve injury or trauma. All right. Cecilia says, please talk about flares. I don't know how to avoid flares. Well, Cecilia, if you come on over to our website and you sign up for our magazine, you will get as a gift, a 40-page flare management guide that explains all the flares, the different types of flares you can have, and it will give you hour-by-hour rescue plans. Pinar says, can you get the digital format for those living abroad? Absolutely. It's $25 a year. It's $25 a year if you want our magazine. So yeah, absolutely. That's what we recommend. And you'll just get the PDF file. All right. All right, my friends. Well, listen, we have been going for about 3 hours now. And Pinar, thank you for the stars. I really appreciate that very, very much. We definitely can use your support. This is not easy. This is not easy. So if you want to support these support streams, please come on over. You can make a donation on the IC Network or just sign up to be a member. $25 a year. It would help tremendously. And again, this is our 19th year of doing our magazine. And there are different types of memberships you can get that gives you more freebies if you want them. All right. Well, listen, I'm going to cut it here because I really hurt my jaw. And the longer I talk, the more sore it gets. Rhonda says, so good to see you. Really helps. Thank you. There will be another like you. Sure, there will be. Rhonda, it might be you. I have terrible spasms, real pain when eating. It feels like my right cheek has been super chronic. I was diagnosed with TMJ years ago. Can you tell me if you experience this pain in the cheek when eating? I haven't. Okay, so there are some very, very good videos on YouTube about TMJ. And the reason why we talk about TMJ is one of the chronic overlapping pain conditions. So there are a group of us who have IC, IBS, vulvodynia, or fibromyalgia, or TMJ. And so for me, I have what's active for me now is TMJ and pelvic floor. My bladder's okay so far. I have a long history of vulvodynia. I haven't had it for a while. Things have really calmed down. But with the stress of COVID, it's just life is hard. And we bring out our stress at night when we're asleep and we grind our teeth. And so when you have TMJ, you have to really look at muscle health. And let's look at what influences TMJ. The first thing we're going to look at, it's going to be the tension in your face, right? And so one of the things they have you do if you have TMJ is you rub along the pathway of the muscle, right? Up like that. And when I touch it on this side, it's quite tender. This side is fine, but my left side is fine. So they will have you rub here, and then they will also have you rub on this muscle up here. And this muscle up here feels really tight and really good. And I think it's because I'm glued to my iPad after dinner. I mean, I'm just holding my iPad and using my iPad and reading books and following Twitter and watching TikTok and all this sort of following my email and all that sort of stuff. And so the looking down all the time, iPhone neck is real. So the second thing we're going to look at is our neck and the health of our neck. We're going to look at the health of our shoulders. Are our shoulders tight? Right? That feels really good. One of the things that they had me do, Rhonda, that I thought was really interesting is if you put your hand in your jaw, so my thumb is rubbing along the inside of my jaw and touching the muscles, right? And I can feel the sore muscle. And so it's kind of like internal pelvic floor massage. You can kind of do internal TMJ massage, but you need to have somebody show you how to do it first. And so it's really interesting, and comparing the two sides is really, really interesting. So that's to get you out of that spasm. But once you're out of that spasm, what we have to do is you got to strengthen those muscles. And so there are also some exercises that will do that. So for example, you can do this. Or they will have you do the side one. And that's where mine is. My jaw slips from side to side. So, okay, you do it on the other side. Or you put your tongue on the roof of your mouth, like you can see my tongue, and then so just going over to YouTube, there's several physical. See that hurt right there. I get a really hard click, and then yesterday it was almost totally dislocated, and I just. You have to be careful how you sleep. When you've got TMJ, you need to sleep on your back. If you sleep on a side like this, you're pushing your jaw up and potentially straining it. And that's what I was doing. And the worst place to sleep when you've got TMJ is on your stomach. And I have been sleeping up until last month. I love to sleep on my stomach because it takes pressure off of my SI joint. And I could feel my whole jaw in the morning moving out, becoming more pronounced. So much so that my front teeth would hurt. My jaw was just sliding forward with the effect of gravity of sleeping like this. And so again, it's going to come back to good muscle health, managing stress well, better, et cetera, et cetera. I have a good neck massager. I used to get a lot of neck massages before COVID, and I haven't had one in a year. And you guys can see my neck gets super tight because I will start doing this. So if you ever see my head doing this, that's just because my neck is super tight. So Rhonda, I think your neck is really, really tight, and you need to work with a TMJ doc or your dentist. And I would also be, if you can, when COVID is better, get some massages on your neck. It's stunning how tight, like, if you go right at the base of your skull and you push in there, holy hell, that is so tight and painful for me. Oh my God, it's just like ridiculous. All right. Okay, so I'm going to give you your homework. For 15 minutes a day, I need you to do something for your spirit and your soul, something that will give you comfort. It's a gorgeous day out here. Get yourself outside and go sit in the sun for 15 minutes, right? Just relax, let the day go. Don't bring your damn iPad like I do. Just breathe. Listen to the birds. It's spring. It's a beautiful time of year. For 15 minutes a day, I need you to do something to improve your knowledge. And luckily, come on. One blog on our website. I have a great writer who writes for us on our website, or just one article in our magazine. But just go to the front page of the IC Network. We do new blogs every week. For 15 minutes a day, I need you to do something for your bladder, your pelvic floor. Get out your wand and do your pelvic floor internal work or follow the diet. And then for 15 minutes a day, I need you to do something that will make you laugh, because when you're laughing, your brain modulates pain. It reduces pain. Laughing is important. Chimera says, have you found any connection between flares and the COVID vaccine? Yes, some patients are reporting short-term flares with the vaccine. Not a lot, but a handful of you are. The vast majority of patients are fine with the vaccine. I got mine 10 days ago. I got the Pfizer, no problems at all. I got my first shot. I'm getting my second shot in another week or two. And ultimately, it's about weighing the risks versus the benefits, because the damage that an active COVID infection can do on your bladder is enormous. We're doing that study. 75% of IC patients who get COVID report that their IC flares. For 25% of them, it's a very, very severe flare. And we believe that the virus is actually probably infecting the bladders in those patients. And for them, they go into a severe flare that can last for months. And the typical therapies that they would normally rely on are not helping them at all. So would I risk a flare for a couple of days for the COVID as for the vaccine as compared to several months of severe pain if I get COVID infection? It's kind of an easy choice, but nobody can guarantee that it's going to be okay for you. We did have one IC patient who had very severe autoimmune and kidney disease, and it affected her. She had one shot, and it did throw her into a short-term kidney failure, but she had a lot of other stuff going on. The vast majority of us are just fine with the vaccine, but no promises. Do your best. They say don't drink alcohol, for 3 months around it. You're not supposed to take Advil or Tylenol before you go have it done. This is all about rebuilding a good, strong, healthy immune system. All right, my friends. Wait. No, it's like that. It's like that. That's a new hug. I wish you well. Y'all have a good week. I'll probably be doing a drop-in this week, though I'm on deadline trying to finish up the indexing of this new book that we're doing called IC 101, which is going to be our new guide for newly diagnosed patients and grizzled veterans. So I'm going to try to get on this week at least once, but I got to finish up this book first. All right? Okay, everybody, be well. Be well. Happy spring. Bye, YouTube.